there were two things that come to mind immediately based on results from some large phase 3 studies. One was the use of adjuvant treatment options in patients with high-risk kidney cancer who've had their primary tumor removed surgically. Today, there is one agent that's widely used based on a well-conducted randomized phase 3 study called KEYNOTE-564 for patients with high-risk RCC, clear cell RCC. And this agent is Pembrolizumab, which was shown to be better than placebo in improving the time to recurrence, disease-free survival in these patients. Both a 24-month and a 30-month look at this trial suggested that Pembrolizumab was beneficial in this setting. And it's widely used as a standard of care option in patients that after removal of their kidney, or in some cases removal of limited metastatic disease, which then renders the patient with no evidence of disease, suitable candidates for this approach. There were several other trials looking to ask if this or similar approaches are also beneficial. There was a phase 3 study reported with the combination of Nivolumab, another PD-1 inhibitor just like Pembrolizumab, in combination with the CTLA-4 inhibitor Ipilimumab, to see if that combination offered a similar benefit. And at least at the time of the analysis that was presented, it looked like there was no disease-free survival advantage with that combination. There are also a couple of other studies, one of which looked at a PD-L1 targeted antibody called Telisotuzumab, and another which had a slightly different trial design, a study design with a trial called Prosper, where Nivolumab was used in a neoadjuvant and then in an adjuvant setting. In both these studies as well, there didn't seem to be a clear meaningful benefit to adjuvant therapy in high-risk kidney cancer patients. So the field is trying to figure out how to handle these sort of disparate and divergent data and understand how best to treat these patients. I think we'll get further insights as data from some of these studies mature and we get more data from other studies. But I thought that was a very important set of data that were presented that shed further light to the field on the state of adjuvant therapy in kidney cancer at this point. There was also a combination of 3 drugs used upfront in the treatment of kidney cancer patients with metastatic clear cell RCC. Combination of Nivolumab and Ipilimumab, which is one standard of care in some patients with advanced clear cell RCC today. And this study asked if the addition of cabozantinib would improve outcomes. And the study showed that there was a disease-free survival advantage. And we'd love to see longer follow-up and overall survival data. The study also seemed to suggest that there was significant toxicity associated with this triplet combination. And that was not surprising. But I think we need more mature data to really try and understand how useful a combination like this, a triplet combination like this, is going to be, and whether it's going to supplant the various doublets that we currently use in most patients as the standard of care for initial treatment of metastatic disease. So these were some of the interesting things that came up at ESMO this year. There were numerous other presentations that were very, very interesting, which I don't have time to go into today.